Before we move on to the next drug class, let's take a look at the RAS, which is the renin-angiotensin-aldosterone system. You should have learned about the RAS in your Year 1 Anatomy and Physiology module, but here's a recap. Angiotensinogen is a plasma protein produced by the liver. When the kidneys detect low blood pressure, the kidneys secrete an enzyme called renin. Renin converts angiotensinogen to angiotensin 1. At the lungs, angiotensin 1 is converted by the angiotensin converting enzyme into angiotensin 2. Angiotensin 2 causes vasoconstriction, which increases blood pressure. And it also stimulates the adrenal gland to produce aldosterone. Aldosterone increases the reabsorption of sodium and water at the kidneys, which increases the blood volume and thus also increases blood pressure. Now let's take a look at the different drug classes targeting the RAS. ACE inhibitors inhibit the angiotensin converting enzyme, which converts angiotensin 1 to angiotensin 2. Angiotensin 2 receptor blockers block the effects of angiotensin 2, such as vasoconstriction and aldosterone release. Spironolactone, which is a potassium-sparing diuretic, blocks the effects of aldosterone, which is the sodium and water retention. Let's first take a look at ACE inhibitors. ACE inhibitors inhibit the angiotensin converting enzyme, therefore preventing the conversion of angiotensin 1 to angiotensin 2. Remember, angiotensin 2 has two important effects. It is a vasoconstrictor, and it stimulates the secretion of aldosterone, which increases sodium and water reabsorption. So now, by reducing angiotensin 2, vasoconstriction is reduced, resulting in reduced peripheral resistance. The secretion of aldosterone, which is responsible for sodium and water reabsorption, is also reduced, and this reduces the blood volume, resulting in decreased cardiac output. Besides lowering blood pressure, ACE inhibitors also offer additional benefits. They have a protective effect on the heart, and we will see later on that ACE inhibitors is used in patients after a myocardial infarction, which is a heart attack, and in congestive heart failure. ACE inhibitors also have a protective effect on the kidneys as it slows the progression of chronic kidney disease, including diabetic nephropathy. Examples of ACE inhibitors are captopril, enalapril, perindopril, and lisinopril. Let's take a look at the side effects of ACE inhibitors. One quite common side effect is a dry irritating cough which does not respond to cough medicines. And this is due to an increase in bradykinin levels. That's because the angiotensin converting enzyme also breaks down bradykinin, which is another substance. ACE inhibitors can also increase potassium levels in the blood. And due to their action in reducing blood pressure, they may also cause low blood pressure and dizziness. Some patients report that they experience an abnormal taste in the mouth, like a metallic or salty taste. Some people may have rashes. ACE inhibitors may cause birth defects, so it should be avoided in pregnancy. Angioedema is a rare but life-threatening side effect where the face and the airways may get swollen and result in breathing difficulty. ACE inhibitors may also have drug interactions with other drugs. So other drugs that may increase potassium, or if the person takes potassium supplements, that could cause hyperkalemia. And if taken together with NSAIDs, NSAIDs may reduce the effect of ACE inhibitors. Next, let's look at angiotensin 2 receptor blockers, or ARBs. As the name suggests, ARBs block the receptors for angiotensin 2. Remember, angiotensin 2 is a vasoconstrictor and stimulates the release of aldosterone, which is responsible for sodium and water reabsorption. So by blocking the effects of angiotensin 2, vasoconstriction is reduced, thus decreasing the peripheral resistance. Secretion of aldosterone is also reduced, thus decreasing blood volume and therefore decreasing cardiac output. Examples of ARBs are losartan, brand name Koza, valsartan, brand name Diovan, irbesartan, brand name Aprovel, candesartan, brand name Atacan, and telmisartan, brand name Mikadis. The side effects of ARBs are very similar to ACE inhibitors, except that they are less likely to cause cough. Hence, those who can't tolerate the dry cough from the ACE inhibitors can switch to ARBs. In terms of drug interactions, they are also very similar to ACE inhibitors. The next drug class, alpha-adrenergic blockers, is another drug that targets the sympathetic nervous system. So now let's do a quick recap again. Looking at the alpha receptors are found in the arteries, and when alpha receptors are activated by epinephrine or norepinephrine, it results in vasoconstriction. Alpha-adrenergic blockers block the adrenergic alpha-1 receptors, which are partly responsible for vasoconstriction. This results in a reduction in peripheral resistance. Actually, the evidence for the use of this drug class in hypertension is limited, but it can be added to the treatment when the blood pressure is still not controlled despite the use of other blood pressure lowering drugs. So these are an add-on medication, and they are not to be used as a monotherapy or a single drug for the treatment of hypertension. Examples of alpha-adrenergic blockers are prazosin, alfuzosin, and terazosin. Let's look at the side effect of alpha-adrenergic blockers. Alpha-adrenergic blockers can cause first-dose hypotension, which means hypotension especially when the patient first starts taking the drug. This leads to dizziness, and because of this, patients are advised to take their first dose at bedtime so that even if they feel dizzy, they are safely lying down and are not so likely to fall down. Alpha-adrenergic blockers may also cause headache, abdominal pain, and diarrhea. Some notes about this drug class. This drug class is actually more commonly used for the treatment of benign prostatic hyperplasia or BPH. BPH is a condition where the prostate gland enlarges and causes difficulty urination. This happens mostly in older men. Another thing to take note of is that if alpha blockers are taken in combination with sildenafil or vardenafil, it can cause excessive reduction in blood pressure. Sildenafil is more widely known as Viagra. Another class of drugs which is used in hypertension are the calcium channel blockers. Now, calcium is required for muscle contraction. So calcium channel blockers block the entry of calcium ions into vascular smooth muscles, and this results in relaxation of the smooth muscle, which results in vasodilation. They also block calcium entry into myocardial cells, and this results in decreased contractility of the heart. They can also block calcium entry into cardiac nodal tissue, such as the sinoatrial SA node and the atrioventricular or AV nodes. So if you need to recap what are these nodes, the SA node generates the electrical stimulus, and it is the pacemaker of the heart. This electrical stimulus travels to the AV node and then down to the ventricles. So by blocking calcium entry into the cardiac nodal tissues, it results in decreased heart rate. There are two main categories of calcium channel blockers. First one is dihydropyridines, whose effects are mainly on the vascular smooth muscle, and it results in peripheral vasodilation. Thus, it decreases the peripheral resistance. Examples of dihydropyridines are amlodipine, felodipine, nifedipine. The other category is non-dihydropyridines, which exert their effects on the heart. So they reduce heart rate and the contractility of the heart, thereby decreasing the cardiac output. Non-dihydropyridines consist of verapamil and diltiazem. Let's take a look at the side effects and interactions of calcium channel blockers. Verapamil and diltiazem can cause bradycardia, which is slow heart rate. So they should be avoided in patients who have heart failure or conduction defects in the heart, as well as those on beta blockers, because beta blockers can also cause bradycardia. Dihydropyridines have mainly vasodilatory effects, and this can cause side effects as well, such as peripheral edema, which is swelling of the extremities, especially the lower legs, hypotension, which is low blood pressure, dizziness, flushing, which is redness of the face, and headaches. Calcium channel blockers may also worsen or cause GERD because they can cause relaxation of the lower esophageal sphincter. Calcium channel blockers are also highly protein bound, therefore they can have many drug interactions with other drugs that are also highly protein bound. Another drug class that is used for hypertension is the centrally acting alpha-2 agonist. Unlike other adrenergic receptors, the alpha-2 receptors are found in the central nervous system and inhibit sympathetic activity. So alpha-2 receptor agonists activate the alpha-2 receptors in the central nervous system, which inhibits sympathetic nervous system activity. This results in decreased heart rate and contractility, which decreases cardiac output, and causes vasodilation, which decreases the peripheral resistance. Examples of such drugs are clonidine and metaldopa. Although they are seldom used in the treatment of hypertension, metaldopa is actually used in gestational hypertension as well as preeclampsia, which is a complication of pregnancy where the person has a very high blood pressure. These drugs can cause a number of side effects. Metaldopa may cause hepatitis, which is inflammation of the liver, as well as Parkinson-like symptoms. Clonidine can cause CNS side effects such as sedation, sleep disturbances, and restlessness. These drugs should not be stopped suddenly because they can cause rebound hypertension if they are stopped suddenly. And that is when they are stopped, the hypertension suddenly comes back and the blood pressure will be very high. The last group of drugs that we are looking at for the treatment of hypertension is grouped under other vasodilators. These drugs relax the smooth muscle in the blood vessels and cause vasodilation, thus reducing the peripheral resistance. These drugs are not commonly used to treat hypertension, but are reserved to treat hypertensive crises. These are medical emergencies where the blood pressure is extremely high. Examples of such vasodilators are hydralazine, minoxidil, and sodium nitroprusside. All of them work in different ways. So for side effects, these drugs may cause tachycardia, that is fast heart rate, and fluid retention in order to compensate for the reduction in blood pressure. So these medicines should be used under hospital supervision. These medicines are usually given with a diuretic to counteract the fluid retention and a beta blocker to counteract the tachycardia. Now putting it all together, which antihypertensive drug should be used? Let's take a look at the MOH Clinical Practice Guidelines on Hypertension. Of course, there are a few factors to consider, such as the individual patient factors, as well as the side effects and drug-drug interactions of the drugs. But in general, the drug classes that can be used as the first-line treatment are ACE inhibitors, ARBs, calcium channel blockers, diuretics, and beta blockers. So now at the end of this lesson, you should be able to list the various classes of drug used in hypertension, state the mechanism of action of each class, identify the common drugs in each class, and state the common side effects and interactions for each drug class.